This episode of the Curbsiders is sponsored by ACP's Internal Medicine Meeting 2020, the premier live, clinical, and practice-related education meeting for internists and subspecialists. There will be over 200 high-quality scientific sessions and many other unique and enriching special events. Visit annualmeeting.acponline.org for more information and use the code IM20CURB when registering.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect the official policy or position of any entity aside from possibly Cash Like More Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to another episode of the Curbsiders, the internal medicine podcast where we bring you clinical pearls and practice-changing knowledge. I'm Hannah Abrams, and today we are rebooting one of my favorite episodes from 2019, Hyperkalemia Masterclass with Dr. Topf. I really wanted to reboot this episode because Dr. Topf walks us through so many helpful pearls for management of hyperkalemia, things like how to decide between calcium gluconate and calcium chloride, when to actually get a follow-up EKG or serum glucose, and he walks us through some of the newer treatments that I hadn't heard about before, like loop diuretics and saline, fludrocortisone, patiromer, and of course, who could forget sodium zirconium cyclosilicate. Probably my favorite takeaway from the episode is that ever since I heard it, I always try and do a mental check. Could this hyperkalemia be urinary obstruction? And similarly, I hope that you take something away from it that you can use with every patient with hyperkalemia. For those of you who haven't heard Dr. Topf on the show before, he's our Cashlak chief of nephrology, although he's better known as his much cooler and more intelligent online alter ego at kidney_boy, through which he employs innovative medical education techniques to teach nephrology. He is the co-creator of Neph Journal Club and Neph Madness, as well as his new podcast, Freely Filtered. And in 2017, he won the Robert Narons Award from the ASN. His day job is as a clinical nephrologist at a teaching hospital where he teaches medical students from Oakland University, William Beaumont School of Medicine, Wayne State University, St. George's, and Central Michigan University. He also teaches residents and nephrology fellows at St. John's Ascension in Detroit. So, since we cover ACE inhibitors and acidosis and even more on this episode, I thought I would lead us into it with my favorite 90s pop music themed Electrolyte joke, which is, how did Ace of Base know when the potassium was too high? They saw the sign. All right, that is it. I have peaked. Enjoy the episode.
Joel, I can't count how many times you've been on the show now, but we are thrilled to have you back. And I know the audience is going to be thrilled to have you back. But in case some of them have never heard of you, can you give them your one-liner?
Yeah, I'm a 49-year-old white male with no significant past medical history. I spend way too much time on Twitter, where I'm known as Kidney Boy. And in addition to being a clinical nephrologist, I'm a lifelong runner. I spend most of my creative energy thinking about ways to use modern communication techniques for medical education.
And you do a great job at it, because we all follow you on Twitter, and it's a delight. So how about you give the audience a pick of the week, since we've kind of gone through all our normal questions with you. Why don't you give a pick of the week?
Yeah. So my family just recently got one of these Peloton exercise cycles, and it's really cool. Have you seen these things? These are they're stationary bikes, but they have this huge screen, and they connect to a studio in New York where they stream spin classes to you. And you'll join a spin class, and there'll be hundreds of people from all over the United States that are participating in these classes. And they kind of give you live statistics that are updating all the time. And everybody's got nicknames, and you see these people that are faster than you or working harder than you, and they're taunting you. They're like they're like, wine girl. You're like, I'm not going to let wine girl beat me. And it's really compelling. I mean, I've never been I'm kind of an outdoor runner, and I've always kind of scoffed at these kind of stationary bikes and stationary treadmills, but this one's cool. I like it.
Yeah, this is critically important. Can the other people see you?
There's no, at least as far as I can tell, there's no video thing.
Okay, all right. Then this is much more appealing to me already. Good. And just to be 100% transparent here, Peloton is not a sponsor of the podcast. We are open to it.
That is true, Paul. We are open to it. So my pick of the week is your local library, and I'm going to qualify that by saying the local
like a jump rope.
So yeah, kind of like a jump rope, Paul. So your local library. So this is something that I got into when I was in San Antonio. This is probably 6 years ago now. I discovered they were advertising this free local library, and they were having ebooks. At the time, it was a relatively newer thing that a library would have ebooks that you could check out. So we joined the San Antonio. They had an e-library, and then they also had your local public library. And just like libraries let you check out like 50 paper books at a time, and some libraries have like unlimited. But then they have these apps associated with them. The two most common that I've seen are Hoopla or Overdrive, and you can just get like thousands and thousands of ebooks and audiobooks. And I mean, this is many of the books that I've recommended on the podcast, a very high percentage I'm just getting from these libraries. So I think it's probably an unused resource, but so I would recommend you check out your local library and
do not do what I did. So I have a book that's overdue for about 7 years. I'm not sure how much I owe. I think it's 5 cents per day.
Is it Tropic of Cancer? That
is a solid reference.
No, I can't even remember what the book is, honestly.
The med students have no idea what that's. I'm just going to leave that sit, Paul. Paul, why don't you give a reference? Give a pick of the week.
Yeah, I'll do both. Yeah, I have to say I've never felt older than you than this episode where you're like, have you heard of this library thing? They're just letting you take books out for free. But no, so not to peek too much behind the curtain, but this is right around the time of New Year's, and so for New Year's Eve, my wife and I made her watch The Monster Squad, which she had never seen. And it does not hold up as well as I hoped that it was. So we watched The Predator. And it weirdly, both written by Shane Black. And that made me think of a better Shane Black movie. So here we go. I'm going to recommend The Nice Guys. It's a 2016 movie. It's directed and written by Shane Black, who I think also wrote the Lethal Weapon movies. He wrote, I believe, the original Predator. A really funny screenwriter. And it's with, you've probably seen it, but probably like the commercials for it, but not actually watched it. It's Russell Crowe and Ryan Gosling. It's set in 1977 LA. There's a lot of fidelity to the background, and it's sort of like a comedy crime film. It is hilarious. I had no idea that Russell Crowe and especially Ryan Gosling had anything resembling comic timing, and they are just incredibly funny together. It is like all of my recommendations, not for children or for most adults. But if you have a little bit of a dark sense of humor and sort of like neo-noir stuff, I would recommend The Nice Guys. From 2016.
I just found that I have a book still from my residency on my bookshelf for the library. My Clinical Guide to Laboratory Tests by Norbert Tietz, which is an absolute classic. I have no idea what my library fine is now, but I've had this for 17 years.
You've outshone me yet again.
All right, Stuart, last chance before we move on to our clinical case.
All right, fine. My pick of the week, anyone who knows that I like video games, there's one specific game that came out. I think it's worth a look if you have a PS4 or Steam. It's a game called Forgotten Anne. I think it's on other platforms as well. It's an independent developed title. It's really, really good. Just, I don't know, take a look at it.
RPG type game or what?
No, it's a side-scrolling 2-dimensional adventure game. So almost like an old school point and click, but it's really, really good. The story's really good. The animation's really good. It's surprisingly well done.
This episode of the Curbsiders is sponsored by ACP's Internal Medicine Meeting 2020, the premier clinical education conference for all internists, where you can stay current while productively earning CME and MOC. Whether you're a primary care internist, hospitalist, office-based internist, or a subspecialist, ACP's Internal Medicine Meeting is a highly efficient way for all internists to keep up to date with the latest medical trends and practice-changing advances in medical knowledge. There will be over 200 high-quality scientific sessions, as well as unique and enriching special events such as the ACP MIT Hacking Medicine Mini Hackathon, the Annals Story Slam, and Wellbeing and Professional Fulfillment micro-presentations and activities. This is also an opportunity to experience hands-on learning through numerous interactive workshops, as well as participate in events, receptions, and networking opportunities. Visit annualmeeting.acponline.org for more information and use the code IM20CURB when registering.
And now we will go on to a clinical case from Kashlak Memorial Hospital. And I believe this is one, Joel, that you had seen. So this was a 66-year-old white male. He was coming in with a chief complaint of cough and fever, and he had been started on trimethoprim, sulfamethoxazole, if that's how you say it, 3 days ago. And he has a past medical history, CKD3, type 2 diabetes, hypertension. His basic metabolic panel, he's got a sodium of 140, a potassium of 5.7, chloride is 110, his bicarbonate is 21, his BUN is 18, and his creatinine is 1.4, glucose 124. So Joel, this is actually a case that you wrote. So I'm just going to read, because I thought they were quite funny. So you gave the choices. How would you manage the potassium? A, you call that hyperkalemia, do nothing. B, stop the ACE, ARB, and trimsulfa. C, some combination of IV calcium, nebulized albuterol, insulin, and glucose. Or D, 30 grams of oral Kxalate. Or E, answers B, C, and D. So we're going to kind of hit all these things in general, but why don't we start with just the diagnosis of hyperkalemia? Does this patient have hyperkalemia?
So the best clue to whether they have hyperkalemia is when you look up the labs. If there's an H next to the potassium value, then you've got hyperkalemia. It's as easy as that.
That's how patients do it. I know that.
Right. And right, you always get in that call. I've looked at my labs doc and I got to go over, the MZV is a bit elevated. I want to talk about that. I'm making the special appointment to see it. No. Yeah. The diagnosis of hyperkalemia is straightforward. That's not where the trickiness comes in. It's just, how do you interpret that elevated potassium? And my dad's a surgeon, and he always impresses me with his knowledge of just general internal medicine. Like he's a good internist as a surgeon, which is always just kind of a bit embarrassing. And he was telling me about a case of hyperkalemia he had the other day. And they were in pre-op holding, and they got some routine labs before they went to the OR. And the patient had a potassium of 6.2, and his resident was running around with like a chicken with his head cut off. And my dad said, just recheck it. Right, because I'm sure this patient doesn't really have hyperkalemia because it's a healthy person going for a cosmetic procedure. They're not on an ACE or an ARB. Like they had no reason to have hyperkalemia, right? My dad reasoned that very reasonably, and sure enough, they repeated it and it was fine. And probably the most common cause of an elevated potassium is just what we call pseudo hyperkalemia. The most important thing to understand about potassium physiology is that this is an intracellular ion. Somewhere between 98 and 99% of total body potassium is located inside the cells. It doesn't take a lot of hemolysis or cell destruction to release a small amount of potassium and dramatically increase the serum potassium. And this can happen with someone who's very enthusiastic about pumping their fist right before the blood draw. It can happen with a difficult blood draw where there's some trauma or they are not able to get a good flow with the blood coming into the syringe. And you can get disruption of those red cells, and you get a little potassium leaks out, and that potassium shoots up. And so whenever you see that elevated potassium, you want to think, does this make sense, right? If the creatinine is 9 and the bicarb is 4 and the patient's on lisinopril, aldactone, potassium supplements, yeah, that potassium makes sense, right? But if in other situations, if it doesn't make sense, get a repeat.
Joel, I think you told me that a pneumatic tube system might be involved. Is that true?
Yeah. So right. There's a couple of situations where you can get pseudo hyperkalemia without problems with the blood draw, with a nice clean blood draw. But if they have a platelet count right around 1 million, they'll get, when those platelets are activated, they release potassium, they release that intracellular potassium. And if you have elevated white cell count, so usually white cell counts over about 100,000, right around there, especially in CLL, so chronic lymphocytic leukemia, those white cells are particularly fragile. And when the blood is bumped or disrupted, they will release intracellular potassium. And there's a couple of great case reports in there about blood being transported by pneumatic tube, and the bumps on the pneumatic tube ride were enough to rupture the red cells and cause hyperkalemia. And I think in both of the case reports that I'm thinking of, the critical test was giving the blood draw sample to the medical student to walk down to the lab. Right? Right. If you can treat your medical student like a pneumatic tube, you can get a clean potassium measurement. And so, it's something to consider. Those patients are usually pretty recognizable. You're already worried about the patient. They got a white cell count of 100,000. Just be aware that potassium may not be true. And there actually was a pretty dramatic example of this. This is not my patient, but a case report in American Journal of Kidney Disease, where a patient had a white count of close to 300,000, and their admission potassium was 6.2, but within hours it was over 10. And nephrology was consulted, and they put in a line, and they started dialysis on this patient with a 0K bath. That means they were dialyzing them against a dialysate with 0 potassium. This is something that I don't think many people do anymore. That 0 potassium baths precipitate a lot of arrhythmias. There's a lot of concern about precipitating cardiac arrest from a very rapid reduction in potassium. But that's what they did in this case, and it was all pseudo hyperkalemia. When they actually measured the potassium accurately at the start of dialysis, it was 3.2.
Oh.
And by the time, you want to point to the nephrologist as not being smart, but they were suspicious of this because the patient had no EKG changes whatsoever with a potassium of 10, and or a theoretical potassium of 10. And when they finally got an accurate measurement, the potassium was already down to 2.3. And they switched the bath to a 4K bath, and they continued dialysis until they raised the potassium back up to normal, and then they stopped the dialysis.
This might not be the right place for this question, but I'll just trust Wado to fix this in post. But oftentimes when we get the lab results back, it will helpfully tell us that a specimen's hemolyzed. When is it okay to not be reassured by that? Like, are there certain other things that we should look at that hemolysis may not just be hemolysis, or is that not a concern?
Yeah, my favorite one. I have an EKG that I always show, and the potassium was listed as 9.7, and it's a wildly hemolyzed specimen, and the EKG looks horrible, right? It's one step away from a sine wave, and this is a case where I think it's a good idea to get an EKG. They're not great tests, but the failure of an EKG is primarily in sensitivity, but its specificity is pretty good, that if you see an EKG that looks classically like hyperkalemia, it's probably hyperkalemia. And in this case, the lab listed this as hemolyzed, but it was clearly a true hyperkalemia. And so, I'm not sure if I have better guidance than that.
If the patient codes.
Maybe that was real.
One of our comments from Facebook was from a friend. He's like, is it true that the first symptom of hyperkalemia is often death? Like that's something that kind of is floating around. It's because if you read it in textbooks, it says, muscle weakness can be a sign of hyperkalemia or irregular heart rate. But when I've read it in the Sabatine book, the pocket medicine book, it's like there can be no EKG changes before the patient basically just codes. So that scared me enough that I usually don't I don't put much in the EKG unless I see something. Then that's information. But like you said, the sensitivity not great.
Yeah. So why don't we kind of hit the EKG since we've kind of stumbled across it already? So there's a nice study of dialysis patients where they just looked at T-wave amplitude and related it to potassium, and there was no significant relationship. P-value was 0.11. And then there's another trial that just looked at a retrospective analysis. They got a bunch of EKGs of patients with hyperkalemia, and they went back and they analyzed them. And the sensitivity, when they were just looking at T-wave changes, even for patients with potassiums between 7 and 9, looking for T-wave changes, sensitivity was only 39%. You're missing 60% of real severe hyperkalemia with the EKG. And probably the most frightening part about it is, I think it was 90 patients that they started with, but there were 14 patients that had damaging arrhythmias or cardiac arrest. And the sensitivity of the EKG in that population was only 50%.
Yeah.
And so even the ones that are going to have horrible outcomes, that EKG not necessarily going to be helpful. And so I'm not sure if it should be reassuring. And it really worries me that a lot of the guidelines say, hey, don't need to treat that hyperkalemia until you see an EKG change. I'm really with what you said about the first symptom can be death. And as that potassium starts to march up, I start to get real nervous. And I'm not so cavalier about not treating that.
I know that's going to be one of the main questions is like kind of thresholds for initiating like the acute therapies for hyperkalemia. And then later in the show, we'll get to kind of the chronic management of people with chronic hyperkalemia or less acute hyperkalemia.
Yeah, there's some pretty interesting data on when to treat. There's this study by Einhorn. I think the lead author is Lisa Einhorn. And she looked at 250,000 veterans and 2 million blood draws. And of that, she found 60,000 of them that were hyperkalemic. But then she filtered, she said, how many of those patients that had hyperkalemia died in the next 24 hours? Okay, so there's 6,000 patients that had hyperkalemia followed by death within 24 hours, which to me, that is a outcome that I'm interested in. There's a lot of studies that'll look at and they'll say, hey, we have a lab value that's hyperkalemia, and then we looked at mortality for the next 6 months or the next 12 months. And I never know what to do with that data. I never know, how could that death 7 months later actually be related to the potassium that you got? But within 24 hours, that catches my attention. I'm not sure if it's causal, but there certainly looks that association's got to be tighter. And, what she found is patients with potassiums between 5.5 to 6, no CKD, had a odds ratio of mortality of 10 compared to patients with normal potassium, right? That's frightening. And if the potassium was greater than 6, that odds ratio for death went up to 31. I don't see people dying of hyperkalemic arrhythmias with potassiums of 5.7. I'm not sure what the cause of death is, but it's a signal. Like hyperkalemia, you shouldn't have hyperkalemia, and patients that have it are profoundly ill.
Yeah, and what are we listing the threshold? Is 5.5 like a good threshold, or do you consider hyperkalemia above 5? I think different sources probably have slightly different answers to that.
At my hospital, elevated potassium is considered 5.5 and higher. What's it at your hospital?
I think that's about it. And that just kind of throughout my training, that was where I was taught that like I pay a lot more attention if I see 5.5 or higher. 5 to 5.5, I'm like, okay, I'll look at the med list and stuff. 5.5, I'm like I'm getting an EKG. I'm thinking, does this patient need tele? I'm looking at the med list. Do I need to give an acute therapy for this patient? That's kind of my thought process. But we, of course, want to know what you do when you see 5.5 in someone with a plausible reason for having hyperkalemia.
Yeah, I will usually, I'll look at adjusting their med lists, and we'll take no acute action for anything less than probably 6.2, 6.3. Like I'll want to correct it, but I'm not sure if I do any benefit if I corrected it within the next hour or two. Mm-hmm. Okay. But it's an abnormal lab value, and I'm going to pay extra attention to them, and I'm going to work on correcting it. I just don't know if you could check an EKG at potassium in 5.5 to 6, I don't think you ever see anything. Mm-hmm. What's your experience? You see much when you check those potassium? You check an EKG at a 5.7?
Usually no.
Yeah, that's my experience, is that I don't see typical EKG changes until you get a potassium north of 6.5, closer to 7.
Mm-hmm. Joel, so a follow-up question there. I was mentioning tele. Do you find that helpful? Like let's just say this patient, let's say we had our patient here in the hospital, K is 5.7. The med list has some things on there that would be plausible that he has true hyperkalemia. What action should we take in the hospital to deal with this?
In those potassiums that are on kind of the lower half of 6.5 below, I wouldn't use telemetry. I don't think you're going to get a lot of additional information from that. If the potassium starts to get a lot higher than that, it'd be something that I would consider. But mostly I would focus, as your potassium starts to get north of 6.5, I'd really focus on acute management.
You mean not all patients need telemetry?
There's a few that don't.
That's a whole nother can of worms, Stuart.
Things we do for no reason.
But it's funny. There's patients that have irritated myocardium. So there's actually a nice study in JAMA that looked at patients that were admitted for acute myocardial infarction between 2000 and 2008, and they looked at what levels of potassium were associated with death and ventricular fibrillation. And their primary outcome was something they called the post-admission mean serum potassium, where they took all the potassiums, excluding the admission potassium, and they averaged them out. And if that potassium was over 4.5, there was an increased risk of mortality. And if it was over 5, there was an increased risk of VFib.
Wait. So, because the cardiologists are always telling us that they want the potassium over 4.
Right. So 4 to 5 was was the dogma that I heard. Right. 4 to 5.
Right. Yeah, exactly.
And they would much prefer it to be a little bit higher than a little bit lower. But this showed pretty symmetric U-shaped curve with increased mortality at below 3.5 and above 4.5. And the article points out that a lot of the data that talked about higher serum potassiums were from an era before beta blockers, an era before revascularization. And so they didn't think that the studies were much smaller. I think the largest one from those times was 1,000 patients. This was 38,000 admissions for acute myocardial infarction.
Okay.
They looked at, I think it was like all the hospitals that used Cerner's EMR, which is actually pretty cool when you can start to take an electronic medical record and kind of go across hospital systems.
Joel, I wanted to throw you one of the questions from social media here. So one of the questions was, can you talk about the acute treatments for hyperkalemia? Let's say that this same patient, we like a couple hours later, let's say 8 hours later, his potassium 6.2. We decide it's trending up. We're not comfortable. We want to initiate treatment. And the question was, can you talk about like how you choose which therapy to give and the duration of therapies? And like they said, should everyone get calcium gluconate? That was one of the other questions.
What about polystyrene sulfonate?
Yeah. So the first thing I like to do is this patient's a CKD3 patient. And so if we can use the kidney to clear the potassium, let's use the kidney to clear the potassium. And in addition, this patient is a diabetic and is elderly and had a non-anion gap. We're not sure if it's a metabolic acidosis, but had a decreased bicarb and a no anion gap. It could be respiratory alkalosis, but it also could be a non-anion gap metabolic acidosis, which would fit nicely with the patient's history on an ACE inhibitor, on trim-sulfa. So in this case, I'd be happy to reach for fludrocortisone. I would be happy to reach for a loop diuretic with saline. There are a number of options in patients that make urine to lower the potassium without reaching for sodium polystyrene or K-oxalate, which is a drug that deserves a dedicated conversation. Let's reserve that for the anuric patient, because that's where you really want to bring in your potassium resins. So if the patient makes urine, first thing, and a super common cause of hyperkalemia is going to be urinary obstruction. So urinary obstruction classically causes hyperkalemia out beyond what you would expect for its degree of renal failure. It really causes a specific potassium secretion defect in the kidney. And so one of the fastest ways that you can correct hyperkalemia is see if they're obstructed and if they are, place a Foley and relieve that obstruction. And so this patient who's a male, right age for benign prostatic hypertrophy, get a bladder scan right away. And if they've got a big full bladder, get that drained.
Love that. I don't know that I knew that. I bet you Stuart knew that.
Well, I just want to ask no, I didn't. I just want to ask a question actually about the.
Hold on. Wait.
Stuart never misses an opportunity to tell you what he doesn't know.
That was the first time I've ever heard that. Can we just all let it sit and all savor it for just a minute? All right, go ahead.
So the question that I wanted to throw to you was, because I've seen this dosed wrong so many times, what is a dosage of albuterol for hyperkalemia? How would you actually dose that? If you were going to give that?
I use 20 milligrams of albuterol.
And to give some idea, how many neb treatments is that?
That's 8 to back-to-back. When you write for 20 milligrams of albuterol, you will get a call from the respiratory therapist going, did you really mean, you meant 2 milligrams, right? No, I meant 20 milligrams. Your standard COPD or asthma dose is 2.5 milligrams. And so it's a lot of albuterol. You will see tachycardia. It is safe, even though you're trying to prevent arrhythmias and you're predisposing them to SVT with this drug.
What about for patients that are on long-acting beta agonists? Does that affect the efficacy of the albuterol in the short term?
I have no idea.
That's a good question, Stuart.
There's a newer one on the market, Olodaterol, that has a half-life of 24 hours. So the question is, is there any utility to short-acting beta agonists now?
I bet you somebody on Twitter will know the answer to that.
Let's rewind a little bit and let's make sure. So what we have is a patient with a modestly elevated potassium, but it's going in the wrong direction and we're concerned. We're going to take a look, make sure they're not obstructed. Secondly, we're going to get an Acute check. The other thing that can cause your potassium to rise dramatically is hyperglycemia. So what you get here is as the glucose goes up, it increases the osmolality outside of the cells. Water goes from the cells and it leaves. And as it leaves, you get something called solute drag that brings all that intracellular potassium along with it. Since they have hyperglycemia, there's a relative lack of insulin, and insulin's important for moving potassium into the cells. And so kind of all that is pushing your potassium up. And it's also super easy to correct. We all know that for acute treatment of hyperkalemia, you can give IV insulin and glucose. But be aware that if they have hyperglycemia driving their hyperkalemia, just bring down the glucose, right? Just give them the IV insulin. Don't throw on the glucose on top of that. And that, if you can correct that glucose, you can bring that potassium down beautifully. I have a case that I always love showing. It's this Chem 7 of a diabetic dialysis patient. They've got they're a dialysis patient, so their creatinine's 9, but their potassium is 9 and their glucose is 925. And they start an insulin drip, and 1 hour later, the potassium is down to 5.2. Right, 9.9 to 5.2, and that's just from giving them the insulin, lowering that glucose down, shifting that potassium into the cells. And that, that turned what sounded like an incredible acute emergency with a potassium of 9.9 into kind of routine, slightly elevated potassium. And all they did was give them insulin. And so respect that serum glucose, correct that before reaching for albuterol, K-oxalate, dialysis, all those other therapies. A, they're going to take a lot longer, and B, this is super effective. So again, keep in mind what could be driving that hyperkalemia, and you can fix it pretty easily.
Joel, I just wanted to ask you, Kashlak has a really conservative policy on this, and this is multiple different Kashlaks that I've worked at. Kashlak North, Kashlak South, Kashlak Northeast. They all had this. So basically, they say that you have to call a rapid response to shift somebody and give them the insulin and glucose, unless they're in the ER or the intensive care unit, because there had been so many instances of hypoglycemia occurring. So how do we mitigate that?
Yeah, so this is something I think is not well recognized. I think Kashlak's really ahead of the curve in terms of managing this. There's been a couple of studies that have looked at the risk of hypoglycemia following acute management of hyperkalemia, and it's pretty consistently about 14% of patients are going to get glucoses below 60. And what I see in our hospital is there's an easy way to order the insulin and glucose from the EMR, but that order does not require nurses to do any follow-up of Acute checks. And so this is, you just got to be conscious of this, that you're pushing IV insulin. We're not used to using IV insulin. A lot of these patients will have chronic kidney disease, and the kidney is responsible for metabolizing insulin. And so when you have chronic kidney disease, you'll metabolize less of that insulin. And two, it's responsible for a lot of gluconeogenesis. And so these patients will have less of an ability to protect themselves from hypoglycemia. And so you got a population that has increased risk of hypoglycemia. You're giving them IV insulin. We're much more used to using sub-Q insulin, and people just don't respect how much hypoglycemia we can cause with this therapy. And honestly, that 13 or 15% of patients developing hypoglycemia, I think, is really just the tip of the iceberg. I think we don't see a lot of the hypoglycemia we cause because we're not checking the Acute checks frequently after we do one of these intracellular shifts.
So you think like once an hour for 3 to 4 hours? Is that reasonable?
I tend to do once every half hour.
Okay.
I continue monitoring the glucose pretty intensively for 6 hours after the insulin goes in.
Okay. Wow. I like it. How long does this treatment last? That's one of the other main questions I'd like you to answer with each of these kind of more like Band-Aid type therapies for hyperkalemia.
Right. You're looking at usually about 4 to 6 hours on insulin glucose and albuterol.
Okay.
Yeah, because again, and that's exactly right, that you have not corrected the situation. You've just put a Band-Aid on that by shifting the potassium inside the cells, and it'll come back out.
I wanted to swing you back. You had mentioned fludrocortisone. I have never used that for this indication, so I'm very excited to hear the logistics of that, like dosing, some specifics, and how we might track that. And then I also want to ask you a little bit about giving Lasix and fluids at the same time, which is, I'm just very interested in the logistics of that as well.
Which I've made fun of a million times.
Yeah,
that's
exactly.
Right, that's forbidden, right? You're never supposed to give fluids and a diuretic.
Right.
And there are a couple of exceptions, and correcting electrolyte abnormalities is one of those exceptions. And you can do it with hyponatremia in some treatment protocols, and you can do it for hypercalcemia in some treatment protocols, and you can do it for hyperkalemia. And that what we're trying to do is use the side effect of these diuretics, which is increased caluresis, increased potassium excretion in the urine, and we're trying to avoid what is typically the primary effect of these drugs, which is to get rid of sodium. We want to neutralize that unless they have some, if they're fluid overloaded. But if they're not, you want to be sodium neutral, and so you give the fluids to replace those fluid losses.
Right.
And in addition, you're going to get more effective. If you take a look at the two factors that regulate potassium handling in the kidney, one of them is going to be aldosterone, and the other one is going to be distal sodium delivery. And by increasing distal sodium delivery, you're going to get increased potassium excretion, right? If you take a look at the,
I can put your figure from the book in there too.
Right. So cortical collecting duct, which is the kind of the business end of the nephron when it comes to potassium handling. You have a multi-step process to excrete potassium. Step one is sodium is reabsorbed through the epithelial sodium channel. And when the sodium is reabsorbed, it leaves a negative charge in the tubule. That negative charge, it acts like a magnet to help suck out potassium. And so diuretics, loop diuretics or thiazide type diuretics, will block proximal sodium reabsorption, so you get increased distal delivery of sodium, which allows more of that sodium to be reabsorbed by the epithelial sodium channel. Same thing about saline. Saline is going to also increase that distal delivery of sodium.
So essentially what I'm hearing from you is to expect a page from the respiratory therapist, the nurse for getting the Acute checks every 30 minutes, and now the pharmacist for the diuretic with saline, and plus or minus the fludrocortisone. Is that correct?
Yeah, your pager will light up.
Okay.
Okay, so I got this. What I like about this, Joel, I've used the Lasix. I've used furosemide to treat hyperkalemia in patients who are volume overloaded because I'm like, oh, they're volume overloaded already. Now I'll get rid of the potassium and I'll treat their volume overload, at the same time. Now what you're saying is for patients who are euvolemic, we want to keep them euvolemic essentially, and we're going to give them saline along with the furosemide or the loop diuretic, whatever one we're giving. I love it. So fludrocortisone, how is that working?
So a lot of times patients, one of the more common scenarios where patients get hyperkalemia is in the type 4 RTA. And the type 4 RTA is going to be is classically a hypoaldo hyporenin complication of diabetes. And if they have low aldo, is there a way that we can replace that aldo? Yeah, we have pharmaceutical aldosterone. It's called fludrocortisone. Standard dose for people that have adrenal insufficiency is usually 0.1 daily or twice daily. And if I am treating hyperkalemia, again, this is not a very rapid treatment. It is something that's going to treat it over days, maybe a day or two. I will put them on 0.1 or 0.2 twice a day, PO. And it works well at reducing the potassium, but you're giving them aldosterone. It's going to raise their blood pressure. It's going to increase sodium retention. And so it's not unusual to see edema in these patients. We know there's a lot of benefits to blocking aldosterone in heart failure patients. And so I'm nervous about using this long term, especially in anybody who's got any type of cardiac disease. This really may be a great way to fix the electrolytes at the expense of a lot of other organ systems. And so I do use it occasionally. I think about it carefully before I do it. Again, I don't think there's a concern if you're going to use it for a day or two, if you just want to get over somebody who's got some hyperkalemia. But I think there's some real questions about the long-term safety of this treatment in patients with cardiac disease.
Got it. One of the other questions from social was, when are you reaching for calcium gluconate? Do all patients get that when you first diagnose hyperkalemia? Let's say they're above your threshold of worry, which you said was like 6.2-ish. So they're above 6.2. Are they all getting calcium gluconate as a first step? And how long does that last?
Can I add one more layer onto that onion? Specifically, is there any indication for calcium chloride over gluconate?
Right. So the active ingredient here is calcium, and the more calcium you give, the more the effect that we see. And the effect that we're looking for usually is normalization of an EKG. Calcium chloride, vial for vial, has 3 times as much calcium as calcium gluconate. So the dose is always a gram. So if you give a gram of calcium chloride, you've given 3 times as much calcium as if you give a gram of calcium gluconate. I don't know what gluconate is, but apparently it's really heavy, right? And so there's not as much calcium in the gram. And there's actually in pediatrics, they actually did a study where they compared EKG changes, and there was a more dramatic effect with the calcium chloride than calcium gluconate, exactly what you would expect. Most of the guidelines will say not to reserve calcium for patients that have EKG changes, and that to repeat the doses until you've normalized the EKG. So and they typically exclude T-wave changes. They're really looking for a widened QRS complex, and that you give calcium and you want to see that EKG narrow. And if it doesn't, you're supposed to repeat the dose. And I think that's one of the things that I see missed more often than not, is that they'll give a dose of calcium and they'll never get a follow-up EKG, and they'll have no idea if it was effective or whether they need subsequent doses. And calcium will work almost instantly. Almost as soon as that blood hits the myocardium, you should normalize the EKG, but it will not last long. And so these patients oftentimes need repeated dosing. I will tell you that I give calcium whenever I get a little bit nervous, and not only when there's EKG changes, but it's, when you're doing that, I think you're treating yourself, because you don't know if you've given enough calcium, because there's no EKG changes to look for, and you don't know when to repeat the dose. But I will say that I'm not immune to that instinct.
So it's essentially you're giving the dose. As soon as that bag's done, you're checking an EKG. If the changes are still there, another dose right away, and so forth.
That's right.
And
That's
then
right.
the limitation for listeners, calcium chloride, it can cause like caustic. If it extravasates, it's a big problem. So usually they won't let you give it through a peripheral line. So usually calcium gluconate is being given, is my understanding. But I guess if someone has a someone has a sine wave,
exactly right.
if someone has a sine wave, maybe you'd risk the calcium chloride if you had a good line. But
I've never heard it pronounced extravasate.
how do you say it, Stuart?
Extravasate.
Extravasate. I mispronounce words all the time, so thank you.
It was extraordinary.
One of my superpowers is mispronouncing words. All right, so that's calcium. I know one of the big ticket items, SPS. Joel, can you talk about that? Does it work?
Yeah. SPS is sodium polystyrene sulfate. And it is a treatment that was, I think it was grandfathered in to the FDA regulation. So there are two studies that were used for the approval of SPS. They were both in the 1961 New England Journal of Medicine. They're both embarrassingly bad by modern standards. One of them has controls, but it shows that the SPS is no better than sorbitol. And the other one has no controls and has about 30 some odd patients whose potassium improved, but there's lots of possible explanations for why that potassium improved. Some of the patients' renal function was getting better, pHs were getting better, just not compelling data by any modern standards. So there was two studies in 1961 that are trash, but they were enough to get this drug approved in the early days of the FDA. And then there wasn't a lot until there was a study in 6 dialysis patients, and they kind of, this was in 1998, and they ran them through 5 different concoctions to increase stool potassium. And SPS was in a few of those different concoctions. And what they found was that there was no significant effect at all using SPS in these dialysis patients to increase stool potassium, which completely blew up the whole theory on how these drugs worked. Now, part of the problem was these patients were not hyperkalemic to begin with. They just took dialysis patients that were stable. Their serum potassiums were 5, and they gave them SPS or SPS and phenolphthalein, which is Xlax, or SPS and sorbitol. And they really couldn't find any effect at all from SP. This really, and the fact that they measured the potassium content of the stool really kind of blew up the theory that this SPS worked.
No pun intended.
Thank you, Stuart.
You're welcome. You're welcome.
But I think it was really, and this kind of led to people kind of reevaluating the data and said, you know what, we've been using this stuff for 50 years. We don't have a good database to support our using it. But in 2015, a real randomized trial of dialysis of patients with CKD stages 4 and 5 with hyperkalemia were randomized to placebo or Kxalate, and these patients had remarkably were able to lower the potassium. Their endpoint was to normalize the potassium, and a lot of patients failed to normalize potassium because their potassium went too low. Right. And again, this was not using SPS in a few hours. This was testing it daily over time. But the data is pretty compelling. The stuff works, and it fits with decades of personal experience, which again is not a randomized controlled trial. But I've seen patient after patient who is anuric and is hyperkalemic, and they get SPS, and the next day their potassium is improved. And I've seen that enough. I'm trying to, I rack my brain for some other explanation for why that potassium went down, and I can't come up with it. And I think we've got now pretty compelling data that SPS does work. It does lower the serum potassium. But the other issue with SPS comes from a study in 1987. This was a surgery study in which they had, it was a case series of 5 patients that received SPS and sorbitol for hyperkalemia, and they developed colonic necrosis, and 4 of these patients ended up dying. There's definitely an association with SPS, sodium polystyrene, and colonic necrosis. You'll talk to nephrologists and you'll ask them if they've had patients that develop this, and lots of them have had it. The classic scenario is a patient who's right after a kidney transplant. And so oftentimes, right after a transplant, the new fresh graft won't start working right away. It's called delayed graft function. And the surgeons always want to avoid doing dialysis in that situation because it gets those patients that receive dialysis get categorized as delayed graft function, and if you look at their outcomes, those patients do particularly worse. Now, I don't know if there's any benefit to avoiding dialysis when they need to, or those patients will also do worse, but the surgeons really try to avoid dialysis in a fresh transplant. And one of the things that'll push them to do dialysis is hyperkalemia. And so they've oftentimes been, will direct or push using these resin binders to avoid hyperkalemia and avoid dialysis. And a lot of them have developed this colonic necrosis. And this is my one case of clear colonic necrosis that I had wasn't a transplant patient. It wasn't a fresh transplant. Kidney had been in for a few months, almost a year. But she had a horrible hospitalization, prolonged partial colectomy, all this because of a KX-late-4 hyperkalemia. And so once people began to recognize that this was an association, that there was colonic necrosis with SPS, the question was, how dangerous is this? How common is it? And like I said, if you talk to a nephrologist, most of them will have a story of one patient who got SPS and then developed this colonic necrosis. But most people only have one, and that's my case. I only have one. There was a nice review in the American Journal of Medicine, 2013. The systemic review looked at 30 articles. It was 23 case reports and 7 case series for a total of 58 cases. That's just not that many cases, right? This stuff, we use a lot of sodium polystyrene. So there was a letter in the American Journal of Kidney Disease in 1991 that said we were using 35,000 kilograms of SPS per year. 35,000 kilograms represents about 1.5 million doses, assuming we're still using as much SPS as we did in 1991, represents 37 million doses over 25 years that the case series represents. So that's a denominator of 37 million, 58 cases over 37 million. That sounds way too rare for me to care about. But if you look at maybe those cases, there's 10 cases for every one that's reported. That's pretty realistic. That's still way too small of a denominator. If you go all the way up to, for every case that's reported, there's 1,000 cases that are unreported. That would be 58,000 cases and a risk of about 0.15%. And that sounds like a risky drug, but it doesn't sound terrifying. And it's hard to believe that there's 58,000 of these cases that have been, 1,000 of these cases, 1,000 unreported cases for every one that was reported. If the disease was that common, I think we would have much more recognition of it. People would have a lot more experience with it. I mean, that would be a situation where this would be happening, monthly on every floor. I just don't think the disease is that common. My sense is this association is real, but it's rare. And in situations where you need to use the drug, it's okay to use the drug. But lots of times people are using the drug when patients have good renal function and other options are available. And in that situation, we shouldn't be using it. Does that make sense?
Yeah. So you're saying that if someone has CKD3, kidneys are working, you jump to a loop diuretic and saline ahead of that, maybe fludrocortisone ahead of that, depending on the patient, change their meds around, etc.
Nursing's going to love you. Now they're checking AccuChecks and changing the bedding.
I'm not very popular in the hospital.
And I think you had, in one of your slide sets I saw, you did mention that patients with a sick bowel, it makes you have some pause before you're going to be giving them SPS.
Yeah, I'm reluctant to use SPS. I'm certainly reluctant for the patient that's already been admitted with a GI bleed or has, a lower GI bleed, something that, or they're, small bowel obstruction. There's a lot of patients that are in the hospital that I would avoid it absolutely. Yeah. So if they have diseased bowels to begin with, I think it's a bad idea.
Okay. I think the last acute therapy that we wanted to bring up was sodium bicarbonate. Does that work?
So if the question is the patient has a potassium of 7.7 right now, and I want to lower that potassium right away, it is not a good therapy. So there's been a number of trials that have looked at it, and sodium bicarbonate has repeatedly failed to lower the potassium. There are some analysis that say if your patient has metabolic acidosis, in that situation, it can help. But one of my concerns is we know that raising the pH is going to lower the ionized calcium, right? Because as you raise the pH, you're going to you're pulling hydrogen ions off of the albumin. That's going to leave a space for calcium to bind to that albumin. So you're going to lower the ionized calcium, which is our primary antidote for the outcome that we want to avoid, which is the arrhythmia. And so I worry that pushing the sodium bicarbonate is neutralizing the highly effective calcium that you may have given previously. And so I'm really hesitant to use sodium bicarbonate for the acute management of hyperkalemia. But when you have the question of a patient who has chronic hyperkalemia, a patient with the type 4 RTA that we've already talked about, the diabetic patient who's running around with a bicarb of 21 or 19 and a potassium of 5.7 or 6.1, I think oral bicarbonate is a great therapy there, and that's going to help the kidneys excrete additional potassium.
Okay.
Whether bicarb work, I think, depends on the scenario that you're using. But if it's part of your, quote, cocktail that you used in the acute management of hyperkalemia, I think you need to reevaluate that. The data does not support the use of sodium bicarbonate in the treatment of acute hyperkalemia.
I feel like we've covered a lot of ground. I think we probably should go back to our original case at some point and talk about sort of what we think actually happened with our specific patient and sort of more the management of, since we've already started this discussion about chronic hyperkalemia, that might be the right transition point here.
Perfect.
Yeah. So we have a patient who's got a new finding of hyperkalemia in the labs. We want to make sure that that's not a pseudo hyperkalemia. Check the labs, make sure it's not mentioned to be hemolyzed. But we have a nice setup for hyperkalemia. We've talked about the patient has diabetes. Patients presumably on an ACE inhibitor for their CKD stage 3 and diabetes. And now we've added trimsulfa. And so trimsulfa blocks the epithelial sodium channel that was the very first step in renal excretion of potassium. And so this drug is going to reliably cause an increase in potassium. Whether that's enough to cause hyperkalemia or not is going to vary from patient to patient. But patients on RAS inhibition, so ACE inhibitors or angiotensin receptor blockers, patients with diabetes, these patients are set up for hyperkalemia, and oftentimes the addition of trimsulfa will push them over into hyperkalemia. And so I would look carefully at what the indication for that drug was, and I would stop it if you can. There's a guy named Mike Freilich who did an interesting analysis of medicine dispensing data and found that use of trimsulfa and patients, I think they were elderly patients that were on ACE inhibitors, had a measurable increase in acute sudden cardiac death.
Yes.
Right. It's horrible to think about, right? You got a patient who's got a sniffly nose. You're like, oh, just take some Bactrim, you'll be fine. and they end up in the morgue. You're like, oh my God, what'd I do? And I think it's going to be a bigger issue now that we're with urinary tract infections. You used to be able to reach for quinolone for that. And now you're really going to be pushed to using trimsulfa because it's got great urinary tract activity, but it can pack a punch.
So the answer is stop the trimsulfa. Would you admit this patient to the hospital? That's one of the big questions I had. This came up all the time when I was working outpatient at Kashlak, where I'd check labs always right at the end of my clinic day. My notes are done. Can I go home? And I check labs, and I have a K 5.7, a K 5.9, someone on an ACE or an ARB or trimsulfa. How do you handle that? What's the sense of urgency there?
Yeah, for me, I don't admit those patients. I call them up. I stop the RAS inhibition, stop any other drugs that might be exacerbating this, and schedule the patient to come in for repeat labs in a day or two.
So Joel, this brings up too, I've had patients, I tell them that they have hyperkalemia. I call them, I say, listen, your potassium's high. I think it's some of the medicines we've got you on. We're going to stop those medicines. I want you to come in a day or two. We're going to check your labs again. There's some certain foods that you might want to avoid just until we get this potassium under control. I tell them bananas and orange juice. Then I see the patient 3 months later, they're like, I stopped eating bananas and orange juice completely. Is there a certain diet that patients need to follow if they've had, hyperkalemia at some point or another?
The nutritional component to hyperkalemia is probably overemphasized. If you take a look at the nature of the potassium in diet, it's not potassium chloride. It's almost entirely potassium phosphate and potassium citrate. But potassium phosphate actually increases renal excretion of potassium. So the additional phosphate is going to help clear potassium. And so it's unclear to me how much this is really going to contribute to hyperkalemia, or is it that how beneficial those dietary changes are going to be. That said, I think it's always a good idea to tell people to lay off of the citrus fruits, to lay off of tomato juice. I think tomato juice is the highest potassium content of anything that you can get. Kiwi is supposed to be extremely high in potassium also. Potatoes.
I'm sure Stuart is Google searching right now.
I actually know. Never mind. I don't want to go into it.
Okay, so I think those are reasonable things to say. I'm not convinced they are a real important part of your therapy. I really think, if you take a look at, I always think about the etiology of hyperkalemia. I divide it into three phases: potassium intake, transcellular location of potassium, and potassium excretion. And all three of those can play a dramatic role in acute hyperkalemia. But if you're talking about chronic hyperkalemia that lasts day after day, month after month months for your patient, that's always a failure of excretion, right? The others may contribute to that, but that chronic hyperkalemia is always going to be a failure of excretion. And that's where I think you need to focus your energy in terms of correcting it, not on the intake, but on getting rid of that potassium. And that's going to be adjusting their RAS inhibitors. So you lower or eliminate the ACE inhibitors, add in a diuretic, neutralize any kind of metabolic acidosis with oral bicarbonate. That's where the money's going to be to correct these patients that are in the outpatient scenario.
I love it.
So just wanted to kind of throw this out there. So the foods that are highest in potassium, I kind of wanted to talk about it just briefly, are generally what are considered the healthier foods, hence the DASH diet, right? Higher in potassium, lower in sodium. Things like lentils, beans, salmon, poppy seeds, almonds, quinoa, kale, all those are very, very high in potassium. And so one of the concerns that I run into in the outpatient setting is saying, hey, let's control your hypertension by increasing your potassium content. And then they come back and now the potassium's like 5.5. They're not necessarily on an ACE or an ARB at that point. What's the concern for overshooting and overtreating when I'm trying to supplement their diet with high potassium, low sodium diet?
My experience is that I have not seen dietary changes alone resulting in those high potassiums. And I would continue to advise healthy diets. The kidney is really good at ramping up potassium excretion. Again, if you run into hyperkalemia, if the lab's not lying, if you had an elevated potassium, if they've got some high blood pressure, I would add a diuretic. But, if the potassium's elevated, I think you're going to have to back off on that dietary advice. But I think that's going to be unusual. I think most patients are going to tolerate it just fine.
Yeah.
Also, I can't imagine a world where I'm like, Mrs. Smith, I'm going to need you to back off the kale. It just
too much.
What a dream. That sounds great. Yes.
Well, bear in mind where I live, and avocados are very, very high in potassium, and everyone loves their avocados and their guacamole. So
it's an entirely millennial clinic. It's all avocado toast all the way down.
Beat me to it, Joel.
All right, Joel. I think some of the last things here, this was asked repeatedly on Twitter. So if maybe you could talk about the safety of potassium supplements when patients are on a diuretic, and then some of the newer medicines, which I don't have much experience with. I'm sure I'm pronouncing this wrong. Patiromer, and then there's this zirconium medication. Those would be some of the last topics we'd want you to hit before we let you go.
Right. So we talked about Caxlate, and so in addition to the concerns about the safety and the concerns about the efficacy, I think the safety issue is a little overblown, but it's a real issue. I just don't think it's a dramatic issue. And in terms of the efficacy, I'm sure that I'm convinced that SPS works, but it's unpleasant to take, right? The nurses hate it. The patients hate it. It tastes bad. There are two new options. There's Patiromer and zirconium sodium or cyclosilicate, right? Zirconium,
sodium zirconium.
Sodium zirconium. Yeah, it's that same thing you bought your girlfriend for her wedding ring. Now ground up in an edible form. These are powders that you mix with water and you can drink. They are very well tolerated by patients, way better tolerated than the SPS, which patients tend to hate, and they're highly effective. And I've had patients with hyperkalemia. The one that I have personal experience with is Patiromer, because it's been available for a couple of years now, and it works great. I've used it in dialysis patients. I've used it in patients with advanced CKD or have not been able to manage their potassium. It has allowed me to continue to use RAS inhibition, so ACEs and ARBs at high doses in patients with bad proteinuria. Even though they were developing hyperkalemia, normally I would have to back off on that medication, which is real helpful for them. The Patiromer has allowed me to continue with the full dose of the ACE inhibition and keep their potassium in a normal range. So I've been impressed with the efficacy of these drugs, and patients don't mind them at all, which is different than they get with the SPS.
Cost wise, is it available? Paul's practicing in underserved.
So I think your Medicaid is going to vary from state to state, but in Michigan it's on the Medicaid list, and so it's available for those patients. The Patiromer, as of today, and I know they're trying to change this, it is only available at specialty pharmacies, and I think it has something to do with the drug needs. It has some temperature restrictions, and it can't get too hot, or it becomes less stable. I'm not absolutely certain on the reasoning there, but you're not going to be able to find it at your standard pharmacy, and that can make it difficult to get.
Okay. Joel, so let's say the final question here, let's say that you're sending someone home on a new loop diuretic. You're going to give them a potassium supplement, but you're worried about overshooting. Is that something that you see often? I don't know that I've really seen that super often, but we had a bunch of questions about it. Like, should I just automatically start someone with a loop diuretic on potassium supplementation?
Right. So there was a study that looked at using loop diuretics and addition of potassium, and using the loop diuretics with potassium had a survival advantage of about odds ratio of about 0.8. So there was a significant reduction in mortality if you give them empiric potassium. And so it seems like the reasonable thing to do. I find that in my practice, I have a lot of patients on ACE inhibitors. I have a lot of patients with advanced CKD. And so I prescribe the loop diuretic and have patients follow up within a week or two to get a repeat potassium, magnesium, make sure that those are fine, and only give the potassium supplement when it's indicated. But if you don't give it, so this is a subsequent study, a reanalysis of the ALL-HAT trial. Remember, the ALL-HAT trial is the largest hypertension trial ever done, 60,000 patients. And one of the arms was chlorthalidone, and about 12% of patients had hypokalemia a year into the study. And if that potassium was not corrected, they had a 20% increase in mortality compared to patients whose potassium was corrected. And so you got to pay attention to these potassium levels. You can't let people go around. You fix their potassium, you fix their blood pressure, but you've left them with hypokalemia. You probably have erased a lot of the survival advantage you've given them by lowering their blood pressure. And so make sure you fix that potassium. Plus, potassium supplements alone have an antihypertensive effect. Right, so you can give potassium chloride, especially in salt-sensitive African Americans, and they'll drop their blood pressure 5-7 points.
Paul, did you have another question before?
No, I really don't. I feel like we've covered a ton of ground.
Yeah,
I'm going to tell you what your question is. Your question is, I got a patient whose potassium's a little bit low. Can I just tell them to drink tomato juice? Can I just increase their oral potassium intake to back that up? And I guess my answer would be, the proof is going to be in the serum potassium. We have pretty good evidence that when patients are on diuretics, they're losing potassium chloride. And when you give them dietary advice, they're replacing it with potassium phosphate. They're not going to fix it. And it's much better to give them mineral potassium or potassium chloride, even though the pill sucks. It's way too big. And patients don't like taking it. One alternative is Morton's low salt or Morton's no salt is actually a potassium chloride granules. And I've had patients take that and they sprinkle it on their food, and it is a useful way of raising the potassium.
Oh, love it. Practical tip.
There you go.
So Joel, first I'd like to ask if you had any major take-home points that you really wanted the audience to remember about hyperkalemia, and then I'll give you a chance to plug anything you wanted to plug before we end the show.
Okay. So my pet peeve about the treatment of hyperkalemia is residents that say, yeah, the potassium was 6.2, so we gave them the cocktail. and I hear this all the time, and then it just doesn't tell me anything. What is your cocktail? Does your cocktail include calcium chloride or calcium gluconate? Did you give them IV insulin? Did you check the glucose afterwards? To me, whenever they say they gave the cocktail, it's like they turned off their brain. They saw the serum potassium and they didn't think any further. And what I would suggest is every element of the hyperkalemic treatment needs some thought before giving it, right? Make sure they don't have urinary obstruction, because a Foley is a great way to correct hyperkalemia. Make sure they don't have hyperglycemia, because if they have hyperglycemia, don't give the insulin and the D50. Give the insulin, monitor the glucose, and respond appropriately. Make sure you use, if you want rapid reduction of potassium, albuterol is great. You're going to need to use an appropriate dose, which is going to be 10 to 20 milligrams. And one of the nice things about albuterol that we didn't talk about, patients that get albuterol get less hypoglycemia from the insulin glucose combination. And then SPS is also oftentimes part of that cocktail, but I don't think it's appropriate in every case of hyperkalemia. Right, SPS is used. I reserve it only for patients that are anuric, where I can't use diuretics and saline to assist with the clearing of the serum potassium. I think those would be my take-home messages.
Paul?
it's every episode with you, Joel, is a joy. And I can always tell when we've had an especially good episode when I just leave with more anxiety than I started with. And you realize that both the problem and the treatments confer higher mortality than I expected. It's always nice to just leave a little bit jittery. So I appreciate the little intellectual goose that you give every single time.
You're leaving like your patient who's just received 20 milligrams of albuterol. Very jittery.
Yep, that's exactly right. A little bit shaky, some palpitations, but I'll be okay.
Joel, as some final parting words to the audience, I know you have your big event of the year coming up in March, and I wanted to give you a chance to just kind of tease that, and we might have, I don't know if you want to talk about this now or later, but the Curbsiders might be doing some special things during that time.
Well, I'll tell you, the event you're talking about is Neph Madness, which is a medical education event that spills over into social media. We're going to lay out 32 different nephrology concepts in 8 different academic regions in a single elimination bracket, not dissimilar to the March Madness NCAA basketball tournament. And we're going to have these nephrology concepts face off against each other. And we're going to have participants predict which ones are going to win. Last year, the Curbsiders had phenomenal participation. You guys generated a tremendous number of applicants or entries into Neph Madness. In fact, you guys won an award, right? You guys, am I right about that? Yeah.
Yeah, you are. You are. I got my Neph Madness hat on here from the swag from winning that.
Oh, we're gonna have great swag this year. Actually, I better order that stuff. So, and what we're looking forward to having the Curbsiders participate again this year, and we're looking forward to doing some episodes with you guys to go over some of the different regions and nephrology concepts. It should be a lot of fun.
Yeah, we're looking forward to that a lot too. All right, Joel, as always, thank you so much for all your teaching tonight, and I'm sure some of this will carry on to social media. I'm sure people are going to have follow-up questions. There was a lot of them. We got to most of them. I don't think we got to every single one, but we got to a lot. This one was packed, so thank you.
Hey, a lot of fun. Thank you.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy, thank you.
Get show notes at thecurbsiders.com/podcast and sign up for our mailing list at thecurbsiders.com/knowledge food to get our weekly show notes in your inbox.
That's right. We're committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. Yes, you, Jim. Jim, please drop it. So please, subscribe, rate, and review the show on iTunes, or contact us at thecurbsiders@gmail.com. Special thanks goes to our social media team, Hannah R. Abrams on Twitter, Beth Garbatelli on Instagram, and Chris the Shoe Man Chew on Facebook. Until then, I've been Dr. Stuart Kent Brigham.
And I've been Dr. Matthew Frank Watto.
And I remain Dr. Paul Nelson Williams, and goodbye.
Good night. And goodbye. Hey, Matt, did you hear about the guy that had too many dates?
I did not.
Yeah, he died of palpitations, but here he's all K.
You got any others?
Did you hear about the couple that cantaloupe?
No.
I hear they're all K as well.
I found that funny because you used the same joke that didn't work twice in a row.
And I'm just envisioning you leafing through a big book of food puns, just looking for the right potassium one.